Hello and good morning. Thank you all for being here today. So we will be beginning our instruction course on retinoblastoma, and we have a distinguished faculty with us here today, a very experienced team in the management of retinoblastoma. It's my pleasure to welcome you all here this morning, and we will be having 6 speakers, and the first is Dr. Seema Das. Can I have Dr. Seema's CV, please? So a bit of introduction about Dr. Seema. Dr. Seema, she is head of oculoplastics and oncology at Shroff Charity Eye Hospital in New Delhi. She has extensive experience in the field of retinoblastoma and ocular tumors. Can I have the first slide, please? This is not connected. कहाँ आ रही है? कुछ भी नहीं आ रहा. इसमें से नहीं, वो डॉक्टर सीमा का जो है वो कहाँ है? लैपटॉप में ही फर्स्ट स्लाइड सीवी की. तो इस पे नहीं खुलेगी? अच्छा ठीक है, तो आप खोल लो. ये तो बंद करो, ये तो बंद करो, ये बंद करो, इसको बंद कर दो. क्या मेरा क्यों दिखा रहा है? फर्स्ट स्पीकर का सीमा मैम का. Right. So once again, welcome you all. Dr. Kasturi and Dr. Swati have just joined us, and we're going to start this session with the first talk. I would like to invite Dr. Seema Das for the first talk, and her topic is classification and staging of retinoblastoma. Dr. Seema is Director in Oculoplasty and Ocular Oncology. She is Director of Medical Education as well as at Dr. Shroff's Charity Eye Hospital in New Delhi. She is also a clinical adjunct faculty at the Department of Ophthalmology and Visual Sciences at the University of Wisconsin, US. Her areas of interest are ophthalmic medical education, ocular oncology, especially retinoblastoma. We look forward to hearing from you.
Thank you, Dr. Bhavna. Thank you for this opportunity. So we have a very selected, focused audience, and I hope it will be an interactive learning experience for all of us. So to begin the session, I'll be talking about the classification and the staging system of retinoblastoma. And we all know the difference between a grouping and staging, and specifically for RB, grouping is usually restricted for the intraocular tumors, and it prognosticates the eye survival, whereas staging gives the overall survival of the patient. So if we look at the classification systems which are commonly employed, and these are the systems which is right now commonly used, and the earlier systems of the Rees Ellsworth and the other system we rarely use these days, because those systems are meant to prognosticate the effect of the outcome of the radiotherapy, which is not the first line treatment anymore. The newer classification systems which is commonly used are the international system of grouping, where the groups are from A to E, and it's a progressively increasing severity group which prognosticates the survival of the eye as well as the treatment modality which we can choose. So generally two systems are used commonly. One is the Murphy's classification, which was proposed way back in 2005, and the others is the classification which was provided by the Shields group. By and large, both these systems are almost the same, except for the group D and E, where there is a subtle difference. If we see the Murphy's system, the group E includes the extensive tumors, specifically the tumors where eye salvage or visual potential is almost nil. Whereas in the Shields system, the eyes where the tumor is occupying more than 50% of the globe and tumor with total retinal detachment are also classified as group E tumor, and this tumor in the Murphy's system goes into the group D tumor. So the difference here is that if we use the ICRB system, there is a possibility that we might overestimate the eye survival, because many of the group D tumors, as per the other classification, goes into group E as per this classification system. So this is something which we need to keep in mind. Otherwise, the system runs from group A to group E. Group A are the small localized tumor, which are less than 3 millimeter in size. As the tumor size increases progressively, it comes into group B, single or multiple tumors. Any macular tumor grows into group B. When there is focal seeding, either subretinal or vitreous seed, the classification becomes group C. When the seeding is diffuse, it becomes group D. And other than that, beyond that, when there is extensive neovascularization and damaged eye, phthisis, and tumors which are involved in the anterior segment, becomes a group E tumor. So moving on to the staging system, this is the international staging system which was proposed by Shantara way back again in 2005. Here again the staging runs from stage 0, where the eye is saved, there is no need for enucleation, till stage 4, where there is metastasis. So again, if we look at this system, it does prognosticate the survival. However, there is a very subtle difference. Specifically, if we see the stage 3, which is a very broad group, where any tumor which is outside the eye, any extraocular extension, is considered a stage 3 tumor. Now, we know that extraocular extension, sometimes the prognosis depends not only on the extent of the extraocular extension, but also what is the pattern of extension, whether the tumor has come out via the optic nerve or whether there is an anterior transscleral or a transcorneal extension. So those sometimes decides the prognosis. And possibly there is a need to revise this classification system also to be able to prognosticate the survival better. So just to look at how well this staging system, specifically for stage 3, prognosticate survival, we just took our own cohort of patient, and this was presented day before yesterday in the free paper session. Here we just took all the stage 3 tumors and we looked at the imaging pattern of extraocular extension, whether the tumor is coming out via the optic nerve or transscleral or a combination of both, and what is the extent of the extraocular extension. For example, if we see the first two pictures, both are extraocular possibly, in fact in the second two pictures, but if you see the pattern of extraocular, the first one, the tumor seems to be predominantly anterior extraocular, whereas the other one, there is a diffuse involvement of the optic nerve reaching almost right till the chiasma. So all of these, both of them are going into stage 3. However, we know the prognosis-wise, both are going to be way different, and the response to treatment are also going to be different. So it's a varied prognosis. And if we categorize according to the pattern and the extent of the extraocular spread, and this is how we did it, the anterior extraocular extension, the posterior till mid-orbit, and then beyond the mid-orbit till the orbital apex. This is the transscleral extension. Similarly, the optic nerve involvement was divided into the intraorbital, intracanalicular, and beyond. And all these together are stage 3, but if we look at the survival outcome, it varies from almost 6% to 50%. So that's a wide range. So there is a need to subclassify stage 3 also to be able to prognosticate the survival outcome better. Now, some of these kind of drawbacks were taken into consideration in the AJCC staging system, the TNM staging system, which combines the clinical grading as well as the histopathological information, and the 8th edition also included the hereditary pattern, and this is RB is possibly the first tumor where heredity has been included in the AJCC staging system because that has a lot of prognostic information and has implication in the management of the patient. So again, the system runs from T, N, and M, and H also has been added based on the heritable trait, and this is the whole classification system. Again, if we look here, there is a catch here, specifically if we look at the CT2. So CT2B includes the tumor where there is vitreous seeding or subretinal seeding, and we know this is something which again is a very wide spectrum. And there is going to be a difference in the prognosis if the seeding is focal versus the seeding is diffuse, which is the classification according to the grouping system. The prognosis-wise, there is a lot of difference in the survival outcome. And in fact, the recent study does show that the globe salvage rate is 49% where there is focal seeding versus 78% where there is a diffuse seeding. But again, both of them are clubbed together into the TNM as one group, which possibly needs a relook and further subcategorization to be able to prognosticate the globe salvage outcome better. The other thing which probably needs to look in the TNM system is the CT4, where CT4A is radiological evidence of extraocular disease, whereas CT4B includes any clinical evidence of extraocular disease in the form of proptosis. Now, if we look at this child, she hardly has any proptosis. This is one of the patient. And we do see some of those patients in the clinics where there is a minimal proptosis or possibly a very subtle one which can be easily missed. But if you look at the imaging of this child, there is a diffuse thickening of the optic nerve. Now, going by the TNM staging, she would possibly go into the radiological evidence of extraocular extension, which is a lower stage in the classification system, so should be prognostically better, but we know the prognosis here is going to be far worse than somebody who possibly has an anterior fungating mass. So again, there is a need to relook at this aspect of the classification in the further revisions, which is going to happen. So these days, again, there are a classification of the seeds also, because with the invent of the intravitreal chemotherapy modalities, there is a need to classify seeds so that we can decide on the treatment, the dose of the drugs, depending on the extent of the seeding, and which compartment the seeds are there. So this was Dr. Munir's work, where based on the anatomical location, the seeds has been classified, as well as based on the morphology, the seeds has been classified into dust, cloud, and sphere, and we all are aware of those. So for a cloud, probably the dose of intravitreal and the frequency of intravitreal are going to be much more than what we do for a dust. The spheres are again something where the genetic basis probably needs a relook, because they are not just simple sprouting from the tumor. Genetically, they can be little different. They might be having new mutations, and hence the treatment response might be variable for them also. Swati has recently worked on the anterior chamber. Sorry, I think the picture is overlapping them. So anterior chamber seeds classification has been recently published by Swati and her group. And here again, based on the morphology, the similar classification that we do for the vitreous seeds has been proposed. And also a clinico-pathological correlation has been proposed. So this was basically the main classification system that we follow for retinoblastoma these days. And the classification and the staging system should help us guide the treatment decision and also help in prognostication. And as far as RB is concerned, with the advent of newer modalities, almost every in the future, there is a need to review the existing system continuously so that it remains contemporary and able to prognosticate the disease and the treatment decision better. Thank you very much.
Thank you, Seema. That was an excellent talk, and very nicely and in a simplified way, you explained a very complex topic to everyone. So are there any questions for Seema regarding staging and classification? No? Okay. So, Seema, why don't you join us here? Yeah. Okay, so we move on now to a very important topic again, the clinical presentation and differential diagnosis of retinoblastoma. I invite Dr. Feroz to come and give us some pearls on this topic. In the meantime, can I have Dr. Feroz CV, please? Yeah, so Right. So Dr. Feroz is a very popular and very competent ocular oncologist, and she recently organized the International Society of Ocular Oncology meeting in Goa, which was hugely successful. And she has lots of awards and honors to her credit. Some of them include the Rashtriya Gaurav Award 2021. She's also in the Women Power List 2021. She's received the AO Best Paper Award on many occasions, also the Asia Pacific Academy of Ophthalmology Achievement Award. She is currently the Secretary General of the Asia Pacific Ocular Oncology and Pathology Society. She was the Congress President 2024 of the International Society of Ocular Oncology, and she's member scientific committee of AIOS, and she is also a visiting consultant at the Amardeep Eye Care Kollam and Trivandrum. She's an adjunct faculty at the Ocular Oncology Services at Malabar Cancer Center in Kerala, and she's also a visiting specialist to Medicare Hospitals UAE. So we look forward to your talk, Feruz.
Thank you, Bhavna. Thank you so much. First of all, congratulations on curating such an amazing course on retinoblastoma. And I would call this an A to Z of retinoblastoma. And thank you very much for having me here, Bhavna. So retinoblastoma clinical presentation and differential diagnosis is something that I'm going to speak here. I would definitely want to acknowledge all my parents, the patients of RB, and treating retinoblastoma takes a village, and this is my village. I acknowledge everyone, and I'm grateful for this journey. We all know that the global burden of retinoblastoma is 8,000 cases per year, and India and China sees around 2,000 cases per year again. And as clinicians, like we have all the distinguished speakers today are dealing with retinoblastoma, and there is a data which says that 2,000 cases per year is not seen collectively by the retinoblastoma specialists. So now the question is, where are the rest? Are they being misdiagnosed? Are they being, not really treated well? And of course, we all know that retinoblastoma can masquerade, and there is a lot of misdiagnosis, and few of them get missed in their diagnosis, and they don't reach retinoblastoma treatment center. And that's exactly why I think this topic today, I'm going to emphasize how you should never miss a retinoblastoma. Good thing about retinoblastoma is that you really don't need any fancy tools to diagnose retinoblastoma. It's purely a clinical diagnosis. With a good clinical acumen, you can definitely diagnose retinoblastoma. And we do have a natural history of intraocular retinoblastoma, starting from a small tumor, which is usually detected in a screening with a hereditary history. And of course, as the tumor evolves and progresses, there is lots of clinical presentation that I'm going to discuss. White glow is not the right glow, and that's exactly what I emphasize in my clinic, and I also emphasize this for creating public awareness. White reflex is the most common presenting symptom, and even unfortunately, due to certain socio-economic challenges and beliefs in India, even a child when presents with a white reflex, there are families that I have where the grandparents thinks that the child is born with a lucky star in the eye. They think, oh wow, this is a child, this is a special child, there is a white spot in the eye, and this is lucky for the family. So that is the height of social beliefs that we see in our society. So white reflects anything which is a white dot. It has to be examined. A detailed, dilated retina evaluation has to be done. Strabismus is yet another clinical presentation where when a child presents with strabismus with or without the white reflex, again has to be dilated and examined in detail. And why does the strabismus happen? Mostly these tumors are in the posterior pole, so there is a vision deprivation, amblyopia in these children, and the eye goes either for an ESO or an exotropia. And this is exactly this child presented with a tumor right sitting in the posterior pole. Ophthalmos, of course, when the tumor is growing and progressing, there can be glaucoma, secondary glaucoma. Two things, it could be an angle closure glaucoma where there is a large tumor which is causing a shallow angle, pushing the lens forward, or it can be a neovascular glaucoma where there is NVI, NVG. So needs attention until, so any child presenting with the ophthalmos, especially unilateral ophthalmos, that an intraocular tumor has to be ruled out, most commonly retinoblastoma. Another thing that you have to keep in mind is medulloepithelioma. This is a 2-year-old male child who presented with a cataract. This is a white, complete total cataract. So can retinoblastoma present as cataract? Well, it is definitely a differential diagnosis. A white reflex is definitely a differential diagnosis of cataract. Well, yes, retinoblastoma can present as a cataract. So an ultrasound B scan is the most easiest diagnostic tool. Although the child has a total cataract, something which was lurking inside was a retinoblastoma. And how does a cataract happen in a child? It could have been a large tumor which has subsequently undergone necrosis to form this small one sitting in corner with the hyperreflective spots that indicates that it is a calcified intraocular tumor in a child. It has to be retinoblastoma. Now, this child had undergone cataract extraction by a clinician, not knowing that there is a cataract sitting inside. And this slide has been, I had taken this from Dr. Santosh Honavar. This is a case that I saw during my fellowship many years back. Finally, the child, after the cataract surgery, the right eye was kept for cataract surgery, planned for cataract surgery, bilateral cataract, congenital cataract, and this is how it happened. After 3 months of cataract surgery, there is a mass which is coming outside. So this was indeed bilateral retinoblastoma presenting with bilateral cataract. 5-month-old baby presented as preseptal cellulitis, has gone through all clinics, has gone to higher centers thinking that it is a preseptal cellulitis. Antibiotics given, no resolution. MRI taken, it is a case of bilateral retinoblastoma with the right eye extensive tumor occupying almost more than 50% of the globe. 18 months old baby as orbital cellulitis. Similar case, child was taken into pediatric unit, treated for orbital cellulitis with antibiotics, non-resolving, and then here you see with an MRI there is a large tumor, intraocular tumor, which is extending extraocular. So orbital cellulitis or a preseptal cellulitis in a retinoblastoma is due to necrosis of the retinoblastoma. That indicates it's a very advanced tumor, and Dr. Seema has already spoken about the classification, and these fall in the group E advanced retinoblastoma. Dr. Seema has already spoken about it. You may not need to have an extensive, or a full-fledged proptosis to have a retinoblastoma, which is really bad. So there is not much of a proptosis over here. There is exotropia. The child has a cataract. There is a yellowish discoloration that you see over here. In MRI, the child has a intracranial extension. And I would say the tumor in the intracranial component is much larger than the intraocular component with the extensive optic nerve involvement. So in order to know and evaluate retinoblastoma, of course it's a clinical diagnosis, but all these children would have to undergo imaging in order to know the extent. A 10-year-old boy diagnosed as fungal uveitis, and the child has undergone, as you can see here, there is sutures over here. The child has undergone vitrectomy in order to diagnose fungal endophthalmitis and fungal uveitis with these lesions. So whenever you see these small white lesions in a pediatric patient, there are a few things that you have to keep in mind. One, of course, retinoblastoma, medulloepithelioma, even lymphoma and leukemia, before you rule out any inflammatory or infective component. What was missed? They had examined the fundus. They couldn't find a lesion, but the lesion was far away in the periphery, which is quite common in an older child presenting with retinoblastoma. And this was also missed because the ultrasound was not taken in the inferior corner. Masquerades, very common with retinoblastoma. They can present as hypopaeon, uveitis, thysis bulbi, hyphema, and vitreous hemorrhage. Any of these presentation in a child, always rule out retinoblastoma, which is lurking inside. We have a clinical spectrum, and this is how it can progress. Now, Coates disease is one of the differential diagnoses. What is differentiating between a Coates disease and a retinoblastoma is Coates disease is mostly a leukocoria because of the exudates, and xanthocoria, sorry, I correct myself. In Coates disease, it's yellow, whereas in retinoblastoma, it is white. Xanthocoria, leukocoria. We have telangiectatic vessels in Coats disease, as you can see here, but in retinoblastoma, you have feeder vessels, where the vessels come from somewhere and just dips inside the tumor. But this, you can actually trace the vessels in Coats disease. Now, whenever this was again a case which was referred as a case of Coats disease, but look for other signs. There is a subretinal seed, there is a vitreous seed, and it can be multifocal. So this is always in favor of a retinoblastoma, but not Coats disease, although you see these vessels which is telangiectatic. Other intraocular differential diagnosis is toxocara granuloma. All these patients were referred to me as a case of retinoblastoma, toxoplasmosis, combined hamartoma, which is white in color, incontinenta pigmenti, all presented with white reflex. So basically, we need to know the anatomy of the eye and what are the structures and pathologies that can present as white reflex in a child, and this is the list of it. So diagnostic challenges, we have delay in diagnosis, we have misdiagnosis, and we have advanced diseases. So it's not difficult to diagnose retinoblastoma. These are the simple tools that you need: examination under anesthesia, 360-degree retina, 360-degree aura, and I would also add 360-degree ciliary body along with the anterior segment evaluation. Seema has already spoken about the classification, and another one is the diffuse anterior segment retinoblastoma, where the posterior pole can be absolutely normal, but the patient can present with either a nodule or these extensive lesion in the anterior chamber. So take-home message from this particular presentation of mine is retinoblastoma is a masquerader. Until and unless you're not sure in a child whether it's leukocoria, whether it's strabismus or a ophthalmos, go for a dilated intraocular examination and an imaging if it is required. Thank you so very much.
Thank you, Feroz. That was a fascinating talk. You really covered all the different clinical presentations of retinoblastoma so beautifully. And indeed, retinoblastoma continues to surprise us, sometimes with very atypical presentations. And so any questions for Dr. Feroz?
I have a small question. Feroz, very nicely you have mentioned that retinoblastoma can be associated or can present with cataract.
Yes.
And though we know that it is not so common, so by ultrasonically, how do you differentiate whether it's an intraocular medullary epithelioma or it's a retinoblastoma in a patient presenting with a total cataract?
Ma'am, medullary epithelioma is a intraocular tumor which arises from the ciliary body. So obviously it will be in the periphery, and you can do a UBM where the location is very important. And another particular feature when you have these anterior segment, involvement is we call it a sago grain pattern. We know what sabudana or sago grain. So it will have this very well-defined lesions. Another thing is you have to look at the lens. There can be a coloboma of the lens. Wherever the medulloepithelioma is present in the ciliary body, at that particular area, you'll find a coloboma of lens or kind of a push of the lens in that particular area. Yeah. And at the capsule, the posterior surface of the lens, you can have these vessels which is growing. This is very, very classical of medulloepithelioma. It's not really difficult, and most of these patients present with secondary glaucoma. Yeah. So retinoblastoma doesn't have the coloboma of the lens, and they can even have a focal cataract where the tumor is, and the sheath of vessels which grows behind the posterior capsule is very, very classical of medulloepithelioma. And of course, medulloepithelioma is much less common than retinoblastoma. Thank you.
Thank you.
And of course, the location, like medulloepithelioma
Body
is,
location,
anterior located. So we move on to the next topic, and this is on super-selective intraarterial chemotherapy for retinoblastoma, which is gaining popularity all over the world and has shown very convincing results in many of the cases of retinoblastoma. So as we all know, we have talked about this so often that when it comes to RB, the goals of therapy are first and foremost life salvage, followed by eye salvage. And now with all these newer modalities of conservative therapy that we have, vision preservation is also becoming increasingly possible. So over the years, the conventional treatment of intravenous chemotherapy and focal therapy has stood the test of time, and it has also given very good results in patients with retinoblastoma as far as globe salvage is concerned. But there has been a paradigm shift now towards other forms of targeted treatments for retinoblastoma, and one of that is selective intra-arterial chemotherapy. So now what exactly do we mean by selective intra-arterial chemotherapy? So this is a targeted form of therapy, and herein what is actually happening is that these chemotherapy drugs, which are otherwise given through the intravenous or systemic route, are injected directly into the ophthalmic artery of the involved eye, and all of this is done under radiological guidance. So now a little bit about the history of IAC. How did it start and how did it evolve over the last few decades? So if you look back, the first trial of the first form of intra-arterial chemotherapy was actually a direct internal carotid artery injection of an alkylating agent, which was done in 1954 by Dr. Algernon Rees. Now today it may sound really that very far-fetched, that how could anybody inject a chemotherapy drug directly into the internal carotid artery, but then that is something that really paved the way for what we have as selective intra-arterial chemotherapy today. So it was a Japanese team which actually developed this technique by injecting the chemotherapy drug into the ophthalmic artery. So Suzuki and Kaneko were the team that were involved in this procedure, and what they actually did was that they used a transfemoral artery approach, and then they used a microballoon catheter which was inflated distal to the ophthalmic artery, and through that the drug was injected. So they call this a selective intra-arterial chemotherapy, because here the drug was going directly into the ophthalmic artery using a balloon tamponade. This was further modified by Dr. Gobin and Dr. Abramson from the New York hospital, where they actually they made this modification and called it a super selective intra-arterial chemotherapy. And in this technique they use microcatheters to enter directly into the lumen of the ophthalmic artery, and this was the technique which was then used by them and then published, and then this became very popular. Now all over the world there are a lot of countries and centers that are using this technique to deliver targeted chemotherapy to the eye having retinoblastoma. Now the question arises is, why do this at all? So we all know that when we give intravenous chemotherapy, there can be toxic side effects that can involve all the cells in the body. So here the rationale of IEC is reduction of systemic toxicity of intravenous chemotherapy and providing targeted drug delivery to the tumor. It also offers an opportunity to use high concentration of drug at low doses, since there is no systemic exposure. This was the paper that was published by Dr. Abramson, Dr. Gobin and their team, and these were the initial results of using intra-arterial chemotherapy for the management of retinoblastoma. Now, what is the challenge? Why it is difficult in especially low resource settings to do this kind of procedure? So you need to first build a team. You need an ocular oncologist. You need an interventional neuroradiologist who will be actually performing the procedure, and you need a pediatric oncologist, because there can be complications which need to be handled, and therefore having an experienced and skilled team in place is one of the biggest challenges. Now, important considerations: not all cases of retinoblastoma can benefit from intra-arterial chemotherapy. So apart from having a multidisciplinary team, one also needs to do a careful case selection. Which are the cases where you really want to offer IAC with an intent to cure? So this is a checklist for exclusion. So whenever there are advanced group E eyes, like there's anterior chamber invasion, secondary glaucoma, like Feroz showed some of the atypical presentations like phthisis bulbi, aseptic cellulitis, or if there is extraocular disease or optic nerve invasion, in these cases we should not even try to attempt intra-arterial chemotherapy. And how is the procedure done? So this procedure is done basically under general anesthesia. The ipsilateral femoral artery is accessed, and then intravenous heparin is used, and the whole procedure is done under fluoroscopic guidance. So a 4 French catheter is advanced first from the femoral artery into the aorta, then the common carotid artery, and then into the internal carotid artery. Throughout the procedure, serial angiograms are performed to ensure that the catheter is properly positioned. And then under roadmap guidance, the microcatheter is then selectively catheterized. It catheterizes the ophthalmic artery origin, and then an angiogram is performed to confirm the position, showing a choroidal blush. The main concern is that the microcatheter should be into the ophthalmic artery and not anywhere else, because you're going to aim for targeted delivery of chemotherapy, and you don't want the chemotherapy drug to enter some other territory and cause damage. Then the drug is prepared, and then it is infused and slowly, manually, over 30 minutes in a pulsatile fashion. Melphalan is the most commonly drug that is used, and then a repeat angiogram is performed after the procedure to exclude a thromboembolic event. Now, why do we use melphalan? We use melphalan because in vitro studies have shown its greatest effect on retinoblastoma cells, and systemic intravenous use of melphalan is limited by severe myelosuppression, so we can't use it in the through the systemic route. Now, apart from melphalan, other drugs have also been used. These include topotecan and carboplatin, but most of them are added when there is no response to single drug melphalan. Then in those situations, if you're using multiple sessions of IC, we can top it up with topotecan and carboplatin. So I just explained the procedure to you, but here I will briefly run the video and show you how the intraarterial chemotherapy is actually performed in the lab. So can you just run the video for me? Does it play? Yeah, okay. So as I mentioned, this procedure is done under general anesthesia, and all this is courtesy our interventional neuroradiology team. So these are the things that we require: a microcatheter, guide wire, a catheter. Here, this is what I mentioned, how the catheter is being advanced up the aorta. First you enter through the femoral artery. Now the catheter is going up the aorta, and this is all under roadmap guidance. So you can actually visualize where the catheter is going, and once it reaches the common carotid artery, then it has to access the internal carotid artery. So here you can see the head and neck area over here, and the catheter over here is being advanced. And now you can see this view where you can actually visualize the eyeball, and you want to visualize. This is the selective angiogram that is being performed. A dye is being injected just to make sure that where is the origin of the ophthalmic artery. Sometimes there is an aberrant supply, and it may not be a part of the internal carotid artery. It may arise from the middle meningeal artery. So therefore you need to verify all these things before you actually select this thing for the procedure. So this over here, you can see this is the ophthalmic artery, okay? And here you can see that the microcatheter is being advanced, and slowly, gradually it is being advanced. It is entering the ostium of the ophthalmic artery, and once it enters the ostium of the ophthalmic artery, again you inject a dye just to make sure that the ophthalmic artery is now selectively cannulated, and the drug that you will inject will go only into the ophthalmic artery and nowhere else. This is the drug preparation of the melphalan, which is done in the lab, and then slowly it is injected over a period of 30 minutes. So these are some of the cases that were treated with IC at AIOMS, and this was a patient at diagnosis. This is after 6 cycles of intravenous chemotherapy. We can still see some activity over here, so we decided to go for IC, and this is after 2 cycles of IC. This mass has nicely regressed. So this is another patient which was not responding just to intravenous chemotherapy, so we thought of trying IAC for this child, and again in this case the active portion of the mass has responded nicely to IAC. But then again there can be complications, and the team has to be ready to tackle with these complications. They can be both local as well as systemic. Local complications mostly are transient and they settle with time, but systemic complications are things that we need to be very vigilant about. There can be vasospasm, thromboembolic phenomena, transient femoral artery occlusion, and there can be anesthesia related complications. So again, it's the expertise and the skill and the competence of the team that is doing IAC that needs to take care of all these issues. Now, failure of cannulation, like I mentioned to you, that there can be an alternative vascular supply to the eye, most commonly to the middle meningeal artery. So sometimes it is not possible to carry on with this procedure. It has to be abandoned or an alternative vascular supply has to be chosen. That is the call of the interventional neuroradiologist. Then again, these are very small kids, so this ophthalmic artery is anyway small in size, and then there can be vasospasm at the time of the procedure. There can be a steep takeoff from the internal carotid artery. So all these are challenges that the team may encounter at the time of the procedure. Now, there's a lot of interest in the literature between what is better, intravenous chemotherapy or intraarterial chemotherapy. And this is one study that was recently published, and it includes a meta-analysis of the efficacy of intraarterial chemotherapy for management of retinoblastoma patients. And this study suggested that IEC may be superior to IVC. It has a higher overall success rate and higher globe salvage rate in group D retinoblastoma. But as far as recurrence and metastasis is concerned, there is no difference between the two treatments. So this is my team, and I'm deeply grateful, and I would like to acknowledge the contribution of everyone in this work. Thank you for your attention. I'll be happy to take questions.
I have a question. So, we are all aware of the complications of intraarterial chemotherapy. We are doing quite a bit at our institute. So, I would like to ask Dr. Bhavna, what is the post-procedure treatment, and how do you follow up these patients? Do you admit them? Do you, what treatment, what drugs do you give?
So at our center, what we do is that all these kids who require IEC, they require admission, 24-hour admission, and we have a cover by the pediatric oncology team. So once the child is out of anesthesia, the child is shifted into the PHDU, where a pediatric oncologist is providing 24-hour cover. Most of the complications, if they have to occur, they usually within when the child is being extubated within the first 1 or 2 hours. That is the time when the child is still kept in the under the care of the neuroanesthesiologist, where the procedure is being done. So after that period is over, the child is shifted to the to our PHDU, where the pediatric oncologist is monitoring the child, and then after 24 hours they are discharged.
What drugs do you give?
Drugs, you mean? If there are no complications, then
Okay, so I think I presented my complications at ISO Goa, and we had a patient who developed severe lid edema, chemosis, and parents were complaining of no light perception. So we took up the patient immediately for a red cam, and we saw that this patient had 360 degrees of choroidal detachment, and a lot of hemorrhages, subretinal hemorrhages were there. So in the past also we had a similar episode long time back in 2013. So we have decided to give them aspirin in the post-op period, and we tell them to report immediately. So this patient who came with edema and choroidal detachment, he just stayed at home and he did not come back. He came 3 days later. So unfortunately that time we could not salvage the vision in this eye. It was just some light perception and counted fingers only. But so for the future, this was very distressing for us, because we had discharge after 6 hours. And so now we have made it a policy to keep the patient in the ward and keep them in the city for at least 3 days. So that is one thing which we have added, and post-operatively aspirin is given.
Bhavna, can
Any
I
other?
add something? Yeah. Well, yeah, I agree to you, ma'am. So just for the delegates here, we also give topical steroid eye drops also. and homide, because sometimes there can be inflammation. There can be tumor necrosis and inflammation. So as an ophthalmology point of view, a topical steroid and a homatropin eye drop is also given, which is for 2 weeks. Yeah.
I have got lots of questions. So once this course is over, because it's really retinoblastoma revisiting me, I'm revisiting it again. So I'll put like some of my queries once we have time.
Sure. So it is my pleasure to introduce the next speaker, Dr. Swati Kaliki. She is the head of the OEU Institute for Eye Cancer at LV Prasad Eye Institute. She's also chair of the ISO membership committee and co-chair of AIOBC-SC Ocular Oncology section. She's a committee member of ARVO AMPC, committee member of WHO Global Initiative for Childhood Cancer, recipient of 2017 ICMR Shakuntala Amirchand Prize, recipient of 2020 ICMR Novartis Oration Award, recipient of 2020 IAPB Vision Excellence Award, and the 2025 Arvo Ludwig I Solman Clinician Scientist Award. She's a prolific researcher and a very competent ocular oncologist, and we look forward to hearing from her. She'll be talking on intravitreal chemotherapy for globe salvage in retinoblastoma.
Thanks, Bhavna, for a very kind introduction and also for including me in this instruction course. A very good morning to everyone. I will try to be quick so that we can be on time. So I'm going to talk to you about a very important component of chemotherapy for retinoblastoma, that's intravitreal chemotherapy. We know that there are various treatment chemotherapy options that are available, and intravitreal is one among them. Now, what is intravitreal chemotherapy? It is a targeted form of chemotherapy where we inject the chemotherapy agent directly into the vitreous humor. The aim is to treat the intraocular retinoblastoma and to minimize the systemic side effects. Now, why do we give intravitreal chemotherapy? Because the advantage of this is that there is direct drug delivery to the site of the tumor, and it has been proven that it is effective in eyes with vitreous seeding, where the other forms of chemotherapy may not reach adequately. Now, why is it that it was not popular before, but it is popular now? If you look into the old publications, it was feared that if we put a needle into an eye with retinoblastoma, it results in tumor seeding along the needle tract. And there is a risk of extraocular extension of the tumor and systemic metastasis. And that's why it was not being used adequately till the year 2012. So what changed in 2012? I think this is the publication which changed our complete understanding about intravitreal chemotherapy. This study was published by Munier's group. They used the intravitreal chemotherapy at a dose of the melphalan at a dose of 20 to 30 microgram dose, and they studied the effect in 23 patients, and they showed the most important message that came out through this paper is that there was no extraocular spread of the tumor in any of the eye, and they could achieve a globe salvage in 87% of the cases. So then started the era of intravitreal chemotherapy. That is the new era in the management of retinoblastoma post-2012. Now, what difference has it made? It definitely has made a lot of difference. It has increased the rate of globe salvage and reduced the need for radiotherapy, because previously if it was diffuse vitreous seeds, which could not be managed with other forms of chemotherapy, we would just send them for radiotherapy, which is no longer done because we have intravitreal chemotherapy. Now, if we look at the three eras of globe salvage, that is when we did not have IAC, when we have IAC, and when we have intravitreal chemotherapy, you can see the gross difference between the three eras. In the era one, that is when only intravenous chemotherapy was available, the globe salvage rates was less than 50%. In the IAC era, the globe salvage increased to 56%, but with the addition of intravitreal chemotherapy, currently the globe salvage for intraocular retinoblastoma is 85%, including 87% of group D eyes and 73% of group E eyes. Now, the drugs that are commonly used are melphalan and topotecan. But do we follow the same rule for every patient? Do we inject the same way? It's not so, because it's not that not all seeds are created equal. So in general, Seema has already shown what are the 3 different types of vitreous seeds that we have. So for type 1, we need about 1 to 3 injections. For spears, we need about 2 to 4 injections, and cloud 2, we need about 6 to 8 injections, which are usually given once in 3 weeks. Now, the technique is very, very important. So it is given through the pars plana route, and it is very important to understand that we are injecting in children. So it's not that the pars plana is present at 4 millimeter from the limbus in every patient. It depends on the age. So in general, you take 1 millimeter for every year. So if it's a 1-year-old child, you inject 1 millimeter from the limbus, 2-year-old child, 2 millimeter from the limbus, 4-year-old child, 4 millimeters from the limbus, and beyond 4 years, you stay at 4 millimeters. And then after we inject, the most important step is to do the cryotherapy at the site of injection even before you withdraw the needle. So you basically withdraw the needle through the freeze and complete the triple freeze thaw cryotherapy at the site of injection. And you shake the eye well. This is because in a child, the vitreous is like a gel, so the drug will not disperse. So you just want to disperse the drug. You shake the eye, like wiggle the eye a little bit, and then give a thorough wash with saline, just so that you wash out any of the drug or any vitreous that has come out of the eye through the site. Now, of course, intravitreal chemotherapy has many good things. The good things here, so this is a child who received intravenous chemotherapy, and you can see that the main tumors regressed. But of course, there are vitreous seeds. The arrows point to the vitreous seeds. So for this child, what do? So you just give intravitreal chemotherapy, and you can see that the seeds completely go away. Of course, it has the bad things as well. Now, in this eye, there are good things and bad things that we see. Now, this is an eye with vitreous seeds, and you can see that with serial injections, the tumor has completely gone away, and that's the good thing, that we were able to salvage the globe. But you look carefully what has happened to the optic disc, what has happened to the vessels, what has happened to the health of the retina. So obviously, it's all damaged. So that's the bad thing as well that can happen with intravitreal chemotherapy. It can also cause the anterior segment complications such as this, where there is iris atrophy, the posterior synechiae that can occur with this drug. So these are various adverse effects that the intravitreal chemotherapy can cause. It can cause retinal toxicity and anterior segment toxicity as well. Now, we recently performed a comparative study of what are the effect of using melphalan versus topotecan. This is just published for those interested to read it. And what we concluded is that both the melphalan and topotecan are equally efficacious, but topotecan has better safety profile, especially in pigmented eyes. Now, there are expanding horizons of intravitreal chemotherapy. If you remember the first slide that I showed, so I told you that it is effective for eyes with vitreous seeding. So what are the expanding horizons? Now, there have been recent publications which have shown that intravitreal chemotherapy, it acts beyond the intravitreal seeds. It is effective against the subretinal seeds. It is effective against the retinal tumor as well. So the expanding horizon is that the intravitreal chemotherapy can be used in selective cases for subretinal seeding and for intraretinal tumor as well. Now, here are some examples that we have treated. So you can see that this child developed recurrent subretinal seeds. We gave intravitreal chemotherapy, and you can see that without any other form of treatment, just intravitreal chemotherapy, the subretinal seeds, the retinal tumor, the epiretinal seeds completely went away. Now, the other new development is that this is the slide that I had shown before as well, where these are the 2 drugs and these are the doses that we use. There are reports now that high-dose intravitreal chemotherapy, especially topotecan, is also very useful. So the high-dose topotecan is almost 3 times the dose of the standard dose, 90 to 100 microgram in 0.1 to 0.2 cc, and it is very effective. And here are some of the cases that we have treated where we gave high-dose intravitreal topotecan when all other forms of treatment were not helping the patient. And you can see the response that the retinal tumor, the vitreous seeds, subretinal seeds, everything went away with high-dose topotecan. So to conclude, intravitreal chemotherapy in today's era, it is safe to be given in retinoblastoma eyes, but of course it has to be given by a trained ocular oncologist. It improves the chances of globe salvage. There is less need for radiotherapy. It is effective not just against vitreous seeds, but also subretinal seeds and intraretinal tumor. And high-dose topotecan is a new emerging option for the intraocular retinoblastoma. Thank you very much.
Thank you, Swati. That was a very elegant talk. And I'm sure there are a lot of questions for you. But we can have them in the end, probably, and move on to the next talk. So we don't have Dr. Santosh Honavar with us, unfortunately. He's busy with other commitments. So Dr. Rolika Bansal is here, and she will be giving the next talk, and that is on, again, a very, very important aspect of treatment, the role of plaque brachytherapy in retinoblastoma. So Dr. Rolika, she's our baby in oncology, doing exceptionally well, and we're all very proud of all her achievements. So she is graduated from Kasturba Medical College at Manipal, and then she went on to complete her MS in ophthalmology, and then fellowships in ocular oncology and oculoplasty under the mentorship of Dr. Santosh Honavar. She then went on to do her ocular oncology fellowship at the Wills Eye Institute, and she is currently working as a fellow in oculofacial, plastic and reconstructive surgery under the mentorship of Dr. Don Gikawa at Shile Eye Institute, University of San Diego, California. And she has numerous awards to her credit, numerous research projects, publications, and book chapters. So we're excited to hear from you today.
Thank you, ma'am. Thank you so much. And I'm glad to be here with all the people that I look up to. And yes, I'm just the baby, and I'm happy to be so. And I'm thankful to Dr. Honavar for giving me the opportunity to see his patients all through these years, and for the talk that I'm giving on his behalf. So I'll be talking on the role of plaque brachytherapy in retinoblastoma. And when we talk about plaque brachytherapy, we have the major radionuclides that are iodine, palladium, and cesium, which are photon emitters, and we have ruthenium and strontium, which are beta emitters. So these are the radionuclides that we deal with. More often, we deal with iodine and ruthenium out of these for treating ocular tumors. And everything depends on the half-life and the energy, so good detailing and information about half-life and energy is important, so that we can land up planning the treatment going forward. So when we talk about the indications of plaque brachytherapy, could be surface neoplasms and intraocular tumors as well, but I'll be specifically talking on retinoblastoma. So when we talk about the history of how plaque brachytherapy evolved, so focal radiotherapy was used for ocular tumors in late 1929 in England by Moore and Associates. They used the radon seeds, and eventually Szilard took up, and Szilard was the one who introduced plaque brachytherapy to retinoblastoma. And then came the episcleral plaques, cobalt plaques, and eventually revisions have been made in the radioisotopes, implant design, the placement technique. And when we look at the current times, iodine is technically preferred in US and other countries, and ruthenium is more preferred in European and Asian countries, and I'm sure that there are still centers which prefer iodine in India as well, but majority of the centers would use ruthenium, and I think the panel would also agree. So when we talk about the old papers, that all the way in 1993, that is when when everything was evolving, and even plaque brachytherapy was used as primary and secondary treatment. So as you can see over here, even 30% of the cases were treated as primary treatment to retinoblastoma. The times have evolved now, because nowadays I think everybody would prefer to reserve plaque brachytherapy as a secondary treatment. And even though the studies were performed, the rate of tumor control and patient survival were pretty much similar, whether as primary treatment or secondary treatment. So when we talk about primary brachytherapy, it is less common. I guess if the panel would agree that plaque brachytherapy as primary would be in cases where you have a very stenosed ostium for IAC, and maybe IVC is contraindicated. So in those cases, we can still think about primary brachytherapy, but I guess primary brachytherapy has its own complications, so we land up keeping it for the reserve. And of course, we have to treat the patient systemically as well. And secondary brachytherapy that is more preferred would be after previous treatment failure in terms of IVC, IAC, cryotherapy, laser, intravitreal topotecan, periocular topotecan, or even a combination of all, which is basically tailored management. So the process of brachytherapy is not that easy. It involves an entire planning, and it involves a lot of people. It's a multidisciplinary approach. You need to have your radiation team as well. So, it's from the clinical assessment all the way to regular follow-ups. Everything, single thing is important in brachytherapy. So let me walk you through those. So when you do brachytherapy, as we prefer it as secondary brachytherapy, it's given in residual tumors. So the patients have been saturated, the lesion is still left aside, not responding to things, then we go for refractory tumors. Tumors which are found over calcified mound but not very high on the calcified mound can also be treated with radiation. If we have tumors overlying a calcified mound like way above 5 mm maybe, then the radiotherapy cannot reach that, so we avoid those cases. We give it within 5 mm of height. And poor vasculature. So these are the lesions where the chemotherapy drugs cannot reach. And what do? So the only resort that would be left would be to proceed with radiation. And macular tumors, of course, because you're not looking at a visual prognosis there, and you want a good response. And even the cases with overlying vitreous seeds, that means just adjacent to the tumor, they respond very well to brachytherapy. So this is the part where the clinical assessment comes in. Then we move on to the part where we have to assess while doing the examination under anesthesia. We must do clear measurements of the tumors. And it's important to know that, because as you are planning with iodine, you can still go to the extent of 8 mm, but with ruthenium, we don't go beyond 5 mm. So it has been proven earlier that the primary treatment tumors in the previous paper, this is paper in 2001 published in Ophthalmology, where the primary treatment tumors were slightly thicker and closer to foveola and optic disc. However, I know that the current trends have changed because we're looking at the secondary treatment only, and we must always do a B scan intraoperative for the pre-planning to make sure that we have the height in our hands to proceed with the dosimetry planning. So documentation is always very important. So when we talk about ruthenium is basically, it's electroplated over a silver foil, and then there is a 0.7 mm of backing and a 0.1 mm of a window. And this entire thing makes a 1 mm plate, which is basically placed over the globe, over the area of interest, and therefore tumor regression occurs. So this is how the ruthenium planning is done. And we must always remember that we prefer a dose range of 40 to 45 gray. And I think we have kind of gone a little comfortable with using 45 gray in our patients, and we always make sure that the foveola is safe still, and we give approximately 11 gray is okay. But of course, as when we are talking about the cases where visual prognosis is not our priority, there we can go ahead with 40 gray to the macula as well. This is not the representation for RB, but this is just to show that there's a lot of planning that goes in. Our radiotherapy team actually has multiple softwares in which the tumor is embedded, and after that a whole planning is done, the calculations are performed, and after which the dose duration is decided. So after the entire dosimetry planning, technically the radiologist tells us that, okay, so now you're going to place the plaque for XX number of hours, and that's how we plan our insertion and removal. So when we talk about iodine, it's slightly different. In the iodine plaques, technically you can decide the exact placement of the seeds, but in radionuclide, you can in ruthenium, you don't decide the number of seeds per se because it's an entire plate. So you have to decide according to the duration there. And we perform the surgical insertion. This is a little video where the peritomy is performed in the region, which is the targeted region. And this is a case where there's a temporal tumor, and you go around the muscles, you hook the muscles for the traction, and you do a careful dissection. You look out to the vortex veins, and from the limbus you calculate the distance, you pass the sutures with the ethylon, and you make sure that there are thin sutures that you're passing. You place the plaque over the eye. You tie the sutures on both the eyelids, and you keep it intact for the desired duration and take the plaque out. Ultrasonographic plaque placement can also be performed to make sure that you are on the right plane. And in Caucasian eyes, we can even do transillumination. So transillumination helps us identify the site of tumor. However, in Caucasian and Indian eyes or Asian eyes, it's not possible to do so. And you must keep in mind that the radiation duration is variable in ruthenium, but in iodine it's quite fixated. So it's calculated by the radiologist, as I said, sorry, radiation therapist. And regular follow-ups are also mandatory, and we must look out for the complications that can occur. Comfortably, radiation does cause retinopathy, maculopathy, papillopathy, cataract, glaucoma, and even scleral necrosis. You must look out for those, even though the tumor control is very high. In this study, the tumor control was 83% in 1 year and 5% at 79 years. And recurrence should also be looked out for, so you must have regular follow-ups. You must call these patients at 4-monthly interval is what we follow. Initially, we start with 1 month, and then we get comfortable and we go for 4-monthly follow-ups. And we are also giving anti-VEGF injections these days, and which helps us out in preventing the radiation retinopathy. And when we talk about the follow-ups, documentation is extremely important. This is a case where over the calcified mount, the tumor has completely regressed. This is a picture of 1 year of 13 months. Life salvage is 100% in our study, with 85% eye salvage and even 65% vision salvage, which is pretty interesting. And we must know that plaque brachytherapy causes sustained regression of tumors, which is what we are looking for. So keeping all of this in mind, it's an entire planning which is required and must be done meticulously. So poor response is also seen in our cases. So this is a case which was stable, regressed earlier. Pre-plaque, there is, like you can see, activity right there. The tumor is completely fulminant, and there were seeds all around, and it did not work. So post-plaque 2 months, the tumor was still refractory. We had to enucleate. So the studies that have been done earlier from 1989 onwards, multiple combinations have been tried. We are now in the year of 2025, and we have symmetrically given ruthenium for our cases with an apex dose of 45 gray. And as I said, we titer it between 40 to 45 depending on the location. And we were able to achieve an eye salvage of 85%, which is a very promising number, and we kind of feel very comfortable using plaque brachytherapy as secondary brachytherapy. Secondary treatment, and of course complications of radiation retinopathy and cataract do occur. So to conclude, brachytherapy is universally acceptable treatment modality given as primary or secondary, but we prefer as secondary. And various radioisotopes, iodine and ruthenium primarily have been used at a radiation dose of 40 to 45, and profile active anti-VEGF have shown protective effect, and excellent life, eye and vision salvage rates can be seen. And I thank you all for listening to my mentors, our patients and their parents, and the entire team for their positive mindset, because everything is all about one day at a time. Thank you so much.
Thank you, Rolika. That was an excellent talk, and beautifully you covered the important topic of plaque brachytherapy. I'm sure there are lots of questions, but we'll move on to the next talk in the interest of time. And the next speaker is Dr. Kasturi Bhattacharjee. She really needs no introduction. She's the current president of the Asia Pacific Society of Oculoplastic and Reconstructive Surgery, and she's also the vice president of OPAI. She's currently a member AIOS ARC. She has numerous publications in high impact journals, many awards, and some of them very prestigious awards of AIOS, and including the Colonel Rangachari Award, the CS Reshmi Award, and the E.T. Selvam Award, many international awards as well. The noteworthy ones being the ARVO Award and the APO Senior Achievement Award, the APO Blindness Prevention Award. She's also been the FRCS examiner for the last 18 years. So it's all yours now.
Is it coming? Thank you, Dr. Bhavna, for the kind words, and I really feel privileged and very blessed to be in this course learning from each and every topic, and wonderful presentation by all my previous speakers. So let me start by mentioning that enucleation may be a lifesaver in grim situation, but true care begins with a healing heart and preserving the spirit of the child. So I'll be speaking on enucleation and the care of the anophthalmic socket. I come to two different scenarios. This is where you see such an advanced retinoblastoma, and these are the situation where the parents will come to you, where we also want to salvage the globe or the vision. And we all know that all my previous speakers have spoke so much about the newer advances in the treatment of the management of retinoblastoma, whether it is an intraarterial or an intravitreal or an intravenous high-dose chemotherapy. And we really want to help this type of situation where she had undergone 3 cycles of intravenous chemotherapy and a single cycle of intraarterial chemotherapy. But there are situations like this. Here, the only aim is basically to salvage the globe or the life of the child. So when we talk about retinoblastoma and enucleation, we all know that enucleation is one of the oldest methods. It is probably a best method for the very advanced unilateral tumor. And also we know with the advances in the chemotherapy and also the histopathology reporting by the oncopathologist, we now have a definite positive impact on salvaging the life, globe and the vision of these children. But what all of us, especially all the residents and the fellows, should know that before you start treating any retinoblastoma, the most important is that you need to do a dilated fundus examination, and it should be cross-checked by a radiological pictures, and the second most important, the photographic documentation. So this is very important in managing any of the intraocular or any lesion related to the face or the eye. And the next important, that when you take the patient to the OT, check and recheck, confirm and declare the eye in the OT. And then this is being followed by the steps of retinoblastoma, where we start with a 360-degree peritomy, and then we separate the tenons in all the 4 quadrants, tag the muscles are tagged in both the interior and the posterior direction, that is towards the towards the belly of the muscle and also towards the cornea. So these are the traction sutures which helps us during the enucleation procedure, and the sutures on the muscle helps you if you plan to go for a muscle covering muscles covering the implant or a myoconjunctival procedure. So these are the oblique muscles which we need to transact, and then once you transact, and the next important that you need to take out the nerve. The nerve preferably should be a little more than 15 millimeter, and if you have something like this 20 millimeter, it is okay. And then you need to also keep some amount of, especially the oblique muscle, the inferior oblique muscle, which helps you identify the globe. Mark the vortex veins is very important, which really helps, and also you can see the posterior ciliary, the long are being marked. Mark any areas of thinning, measure the diameter and the thickness of the optic nerve on the table, which needs to be mentioned to the pathologist, and then you see the pliability of the dura sheet and also the any vessels that can be seen. Once this is being done, and then you go for the reconstruction, where we put the implant posterior to the posterior tenons, and once you close this in 3 layers, first the posterior tenon followed by the anterior tenons and the conjunctiva, it should be the direction should of all the 3 layers should be separate, where if the posterior tenon is sutured horizontally, anterior should be sutured in the vertical direction, then again the conjunctiva needs to be sutured in a horizontal direction, and this helps in preventing any of the exposure or migration of the implant. And lastly, we give the conformer followed by a temporary tarsal referee. So the most important thing what we should emphasize, that we need a good length of the optic nerve, because we know that central retina artery enters the optic nerve approximately 10 to 12 millimeter from the optic nerve head. So 15 millimeter or more is optimal, and then we need to give traction, especially with a 4 silk suture. Strumming of the optic nerve is very important before we go for the enucleation. You can use a straight or 15-degree curved scissor, and then once you engage, once you hold the optic nerve, try to take it out with a single non-hesitant cut. and these are the sites you need to mark it before you send it for a histopathological examination. And once it goes to the pathology department, this is how they process the specimen. Sometimes they also do a transillumination test, which Rolika was mentioning, and then they go for a grossing. And the most important thing what we need are what are the high risk factors. Like you can see this child having the choroidal involvement, because it really helps you to prognosticate the disease and how do we further go ahead with the treatment to salvage the life of these type of children. The optic nerve examination is very important, and they should specifically mention to us whether the cut end of the optic nerve is being involved, and also if they can see any of the seeds in any of the specimen, whether the seed in the subretinal or in the vitreous cavity. It really helps us to know how do we go ahead in salvaging the life of these children. And these are some of the seeds, the RBCs that you can see, and this is what we have also reported in the Indian Journal of the Ophthalmology, where we had done an electron microscopy. So once it is done, enucleation has been done. Now the next step is the care of the anophthalmic socket, which is very essential for preventing the contracted socket. During the surgery, we need to give an implant, because if we do not give an implant, there's every possibility that 20 to 50% contracture not only of the soft tissue but also of the bone can occur, because it's a growing child. And then what we see, they come up with a situation which we call it the anophthalmic socket, and the contracted socket. So the goal of an anophthalmic socket is that we should have adequate volume, a good contour, a good motility of the prosthesis, and a reasonably good and a comfort. So these are some of the children where I have operated long time back, almost 18 to 20 years back, and because the layered suture has been done, you hardly see any types of exposure or migration. This is a child I want to show when we had done the operation almost when he was 2 years of old. Then 19 years later, he comes to me. Now he has become conscious. He is not liking this superior sulcus deformity, which is a sign of volume loss. So this can be managed non-surgically by giving a dermal filler, which is a hyaluronic acid filler of high G prime. And once you see the superior sulcus being overcome, so that means you have given him the volume back. Then again the same child comes to me. Now he is 24 years of age. Again what happens, because the hyaluronic acid filler, which stays for max approximately 2 years, again a second more higher G prime filler I had to give him, because it will hardly stay for 3 years, but he doesn't want to undergo a repeat operation. So best way is to give by cannula, because you are really working in a very vital part of the globe, of the orbit socket. And then once you give a higher G prime hyaluronic acid on the table, you can see that you have really given a good volume to this child, and this will stay for another around 4 to 5 years. So this is what he looks on the table, and this is how, if you really look back to his history, this is how he was 2 years ago, and then when he's 19 years, and now he's 24 years of age. And this is the same implant that I have given to him. That means approximately around 22 years back, and this implant had not shown, and it's a MedPore implant. Though we know the porous implant, the chances are much higher, but this has not gone for any exposure or migration. This is another girl having enucleation when she was a child, and this is the same thing which can be managed. But there are situations, I'm going fast, I'll finish it within a minute. There are situations where there's only volume deficient, and this can be done either with a hyaluronic acid, or you can go or you can have a secondary ball implant, which you can see it really works very much and is a more permanent solution. But when there's a loss of both the surface and the volume, then you have to do a dermis fat graft. And when you do a dermis fat graft, if you have some, I usually use PRF nowadays, because I feel that the healing is so fast that you can give a prosthesis as early as 3 to 6 weeks. And then and especially in situation like this, when previously people used to go for EBRT. So these are the children, now they have grown up, and you see a situation like this where they have not only a loss of volume but also the bony contracture. So these are very challenging situation, because it was done almost 20-25 years back, and now these children, they want a better cosmesis. And when you see a socket with so much of contracture, being an oculoplastic surgeon, we need to help them. So here you have to work both on the bone and also in the soft tissue. The best way which I have developed, this is one of my way of how to work for a contracted socket is to anterior migration or anterior mobilization of the maxilla, and then what you do, you follow, and then you need to fill up the soft tissue loss with the temporalis muscle flap. So this is really helping him, and this is what he comes in the post-operative period. And when you look to the pre-operative picture, at least now we can give him a prosthesis, though he had undergone multiple surgery elsewhere, almost 6-7 surgery before we had done a temporalis muscle flap. With this, I would like to mention that enucleation can be emotionally and physically challenging, but it is definitely life-saving procedure for the best chance for the long-term survival. So we should keep our minds like parachute because they work best when open. Thank you very much for your patient hearing.
Thank you, ma'am. That was a very elegant presentation, and you've really beautifully shown how these children after enucleation can be rehabilitated so well. So we move on to the next, which is the last talk of this session, and that will be given by Professor Usha Singh. Again, it's a very important topic, especially from the point of view of Asian eyes, orbital retinoblastoma, which we see quite a lot of it. So ma'am is going to talk to us about the challenges and solutions. So before she starts her talk, can I quickly have the slide of her introduction, please? Okay, so Professor Usha Singh, she is currently Professor of Ophthalmology, specializing in oculoplastics and oncology at Advanced Eye Center, PGI Chandigarh. And she is also the past president of the Chandigarh Ophthalmological Society and past executive member of AIOS. She's an OPAI member since 1998, and her areas of special interest are retinoblastoma, vascular lesions, ptosis, and orbital disorders. We look forward to hearing from you.
Thank you, Dr. Bhavna, and good morning, everybody. And we are at the last talk, and I'll be talking on orbital retinoblastoma. So what are the challenges we are facing? So retinoblastoma, the extension of the tumor beyond the coats of the eyeball with clinical, radiological, or microscopic evidence is termed as orbital retinoblastoma. And the presence of orbital invasion is associated with 10 to 27 times higher risk of systemic metastasis, and it carries a poor prognosis with mortality rates ranging from 25 to 100%. It's more prevalent in the developing world and Africa. South Asia has the highest burden of 43%. And 10% of these patients of these orbital, they presented with stage 4 tumors as per this latest report in 2024. Retinoblastoma with and without extraocular extension, we can see that this as orbital retinoblastoma is also a part of the extraocular tumor. So we see that the highest incidence is in the low income countries, 31%. It's also associated with income, the low middle countries having the highest burden, and it's also associated with a lag time from the time of onset of symptoms to presentation in nearly about 6 months, 6 to 7 months. So the 5 types have been described by Dr. Santosh Honawar in his article, Primary, Secondary, Accidental, Microscopic, and Overt. So a patient with orbital retinoblastoma needs a complete workup from MRI, detailed examination, lymph node which need to be biopsied, CSF malignant cytology, bone marrow aspiration biopsy, X-ray chest, ultrasonography of the abdomen, post-enucleation evaluation by the pathologist, and some of the cases we can do bone scan and PET scan, especially it is helpful in picking up subclinical meds elsewhere, wherever required. So can MRI predict high-risk features? We can see that the accuracy ranges from 93, it is in the ciliary body and scleral invasion, which is from 93 to 98%. But a recent meta-analysis of 12 studies, the pool sensitivity was 61% and pool specificity was 88%. So orbital retinoblastoma treatment is by intensive multimodal treatment protocol, and because no one procedure is sufficient to control it, and so we give chemotherapy, surgery, adjuvant chemo, and EBRT. When it comes to chemotherapy, we are giving high dose chemotherapy with the carboplatin dose of 28 milligram per kg per day. So here is a patient with primary orbital retinoblastoma, and bone marrow and CSF are negative, and patient has till now he has received just 2 cycles, but he will be undergoing enucleation. This photograph which is seen after chemo is after 2 cycles of chemo, and then he'll be subjected to radiation to the entire orbit. Primary orbital retinoblastoma, the radiological evidence we can see over here, there is a extrascleral, looks like extrascleral extent where the optic nerve is thickened, but however, on MR, patient has received 6 cycles of neoadjuvant chemo, underwent primary enucleation, and the histopathology, the optic nerve was involved with the anterior chamber and ciliary body involvement also. So he was given, after the enucleation, he was given high dose adjuvant chemo and EBRT to the optic nerve and up to the optic chiasma. So this is the protocol. In secondary orbital retinoblastoma, you can see that it is viable tumor cells are seen in the orbit in eyes with clinically undetected extraocular extension or unrecognized intraocular perforation of the eyeball, or there is a residual tumor at the optic nerve transaction. So the high-risk features post-enucleation in intraocular retinoblastoma. So these are high-risk features are helpful to assess the risk of systemic metastasis, but there is a difference of opinion regarding the HRF among the ophthalmic oncologists and pediatric oncologists. And while there is consensus on the post-laminar invasion, tumor at resection margin, and extrascleral extension. So this is what the oncologists, pediatric oncologists agree to. So there is a anonymous survey of 27 oncologists. So majority of them, they agree that post-laminar infiltration, optic nerve and involvement of the optic nerve transaction and extrascleral tumor extension. But there was difference of opinion on the other factors. So there is a need to arrive at consensus definitions and conduct prospective multicentric studies. So here is a patient, a young patient who underwent enucleation, and since the optic nerve was free, the histopathology, there was an antechamber invasion, as we can see over here on the histopathology slide. So this patient, but the optic nerve was free, bone marrow was negative. So this patient was not considered for adjuvant chemotherapy by the pediatric oncologist, and this patient came back 6 months later with an orbital mass, and finally he was subjected to high dose chemotherapy and EBRT, and currently it's 4 months, 10 months for post follow-up, and he's doing fine. So this only emphasizes the point that we need to consider some of these high-risk features, and we need to have studies. And this is a study of orbital recurrence from the Western, this is in 2007, and this is from the Western world, and it gives a percentage of only 4.2%, whereas it is much higher from the Asian countries and the developing countries. Accidental orbital retinoblastoma, I have not seen this in this thing. However, it could occur during the inadvertent perforation, during the enucleation and fine needle aspiration biopsy, or intraocular surgery in an eye with unsuspected retinoblastoma has been done, or a past planar vitrectomy has been done for a misdiagnosis. Here is a case. There's a 4-year-old patient who has been past planar vitrectomy has been done for suspected foreign body in the eye. However, this was detected on the table. Retinoblastoma suspected. Intravitreal injection melphalan was given. Biopsy was sent for cytology, which confirmed it. And the suturing of the vitrectomy ports triple freeze thaw. Conjunctiva was washed with saline and flushed with melphalan. Cytology confirmed this. So the guidelines for treatment of accidental retinoblastoma have been given, and when vitrectomy is done, then enucleation with 4 millimeter of margin of conjunctiva around the entry site, which is removed en bloc, and high dose chemotherapy and radiotherapy are given. So this is the protocol. Overt retinoblastoma is again, if you find a mass which is unsuspected, and again this treated with a high dose chemotherapy. So here is a patient with the bone marrow involvement. Rest of the were negative. So this patient received radiation to the entire orbit, and he underwent, since the bone marrow was positive, he underwent autologous stem cell transplant. He had a very stormy course and admitted in the hospital for 2 months, and but he has recovered from it, and he's doing well. So with intracranial extension, we are currently giving only palliative therapy. So orbital retinoblastoma comes under CT4A and B, and response to chemotherapy could be complete as seen over here, and it could become thysical, and then it's enucleated as seen here. So surgery, the main aim is to remove all the residual microscopic tumor, getting a long optic nerve stump, and preoperative MRI CT can help in guiding the surgery. With extraocular extension and orbital retinoblastomas, metastasis occurs in 67 as per this report, and death is seen in 63%, especially in patients with patients having extraocular extension. In Asia, the death rate is highest in South Asia and Southeast Asia. Coming to the summary and conclusions, orbital retinoblastoma continues to be an important problem in South and Southeast Asia. Thorough clinical examination, a good MRI with a good protocol and CT at staging helps diagnose most of these cases. Multimodal protocol-based therapy ensures best outcomes. Careful surgery and detailed histopathologic analysis is important to avoid missing out on microscopic orbital retinoblastoma. Spreading awareness, early initiation and compliance to treatment can help prevent progression to orbital. And these children are kept under lifelong follow-up. We have to watch out for second tumors, as we can see in this image over here. And all are advised to get the genetic testing done. Thank you very much.
Thank you, ma'am, for very nicely summarizing the challenges and solutions in orbital retinoblastoma. That brings us to the end of this session, and I would like to express my gratitude to all the faculty here for sparing their valuable time and sharing their insights with everyone. I'm also grateful to the faculty of the next session for their patience, and we wrap it up now. Everyone have a lovely day. Thank you for attending this session.
Thank you, Bhavna. I think this is one of the best retinoblastoma instruction course that I've ever attended. You covered the entire, A to Z of
Feroz,
RP.
we
Thank
left
you.
intravenous chemotherapy for next time.
Okay.